Hey team, Ben Onofrio here. Just following up from our recent little post in my Facebook group about the recent article by Jared Power in regards to is exercise therapy the right treatment for rotator cuff related shoulder pain. So I just thought I'd kind of put my 2 cents worth, I'll let you know what I sort of think, and I'd love to have some sort of discussion down in the comments below to see what you guys think and what resonates or what challenged some of your thoughts and beliefs. Obviously, I'm just referring back to some of my notes down here, but as we can see through this paper, exercise therapy's had a fair bit of scrutiny, much like even manual therapy in general of late. So I think I'm probably in a similar position when I started reading this article, thinking about my biases, my practices, how I've kind of progressed over my 13 years of becoming a physio through undergrad to being a new grad to becoming postgrad, doing my sports and exercise and MSK Masters, and sort of how I've transposed or translated the evidence into my clinical practice. So, I still think I bounce between a combination of manual therapy and exercise, sometimes in isolation, sometimes together, depends on that patient in front of me. So I think it always comes back down to what the patient wants and what they think they need and what we think they need, and having that therapeutic alliance to kind of be on the same page is probably the main important thing to start with there. Obviously, just to go back to manual therapy, I'm confident enough in my manual handling, my skills, my training, my experiences throughout my journey so far. Having good mentors that have shown me good ways to do things or better ways to do things has also definitely helped build my confidence in my skills with that. Similarly, through my exercise prescription skills, having to work in top level sport, working with athletes every day, not just from a shoulder perspective, but lower limb rehab. I guess the more you do it, the better you're going to get at it. So similar things that I think from an experience perspective will help with manual therapy and exercise, just for my little insights on that. I guess the key things, if I'm just looking back at my notes here, the article does highlight that there is a fair bit of uncertainty behind exercise therapy, but it still highlights that it still should be a principal treatment for rotator cuff related shoulder pain, which supports my bias. There's lots of different ways we can manage a patient with rotator cuff related shoulder pain, and the evidence sort of shows that there are similar or equivalent effects depending on what you do, whether that's a passive modality, active modality, or a combination of. So it doesn't mean that it shows that one's not more superior than the other. There are lots of holes and gaps in the research that still need further investigation, but at least we know that we've got treatments that can help, no matter how big or small, or unfortunately sometimes the evidence can be quite poor when you look at it through a systematic review or a meta-analysis, that they might have some great clinical implications, but when we look at the quality of the study, that can sort of reduce our trust and reliance on the actual results we're getting. So as we said, it highlights that we still don't know the causal pathways in how exercise works, specifically with shoulder pain as well. Is it the perfectly programmed exercise prescription and the exercises you choose and how you progress them, or is it the fact that we build a good relationship with our patient and that we're progressing their exercises, they trust us, they're building strength, they're building confidence? We still don't know. So, but I think those two examples are equally as important, to have half an idea what you're doing when you're prescribing an exercise based on why you're doing it and your reasoning behind it, as well as does the patient value that exercise as much as we sort of value that exercise as a therapist. So just some food for thought there. We do know at least that exercise therapy from a shoulder perspective demonstrates a moderate effect of uncertain clinical importance when compared to no treatment or no exercise control, nor is it more superior to a realistic sham treatment, and it doesn't outperform an education program. So I guess if they're all showing similar benefits, then to me that makes me think I need to make sure I've got a sprinkle of each of those components whenever I'm managing a patient with rotator cuff related shoulder pain. So hopefully I'd like to think I can educate them on their condition, their prognosis, give them some exercises that they value, progress it in a timely and fashionable manner, and give them some value and some bang for their buck with some direction and some goal setting. So we do know that it has a comparable effect to shoulder surgery and injections. Obviously, it's a cheaper alternative compared to surgery, for example. I still believe that it should be our sort of last resort after a good conservative rehab program, but that's my thought and what some of the evidence sort of suggests as well. as I said, I do think that the patient experience is very important. That's another thing that this highlights. So once again, the proposed causal mechanisms suggest an improvement in strength, improvement in psycho-emotional status, and overall health improvements as a part of exercise and rotator cuff related shoulder pain rehab seems to be important to patients. So the other side of the coin, not just what we think as their therapists. So sort of summarising what I think, that this sort of paper supports my bias, or my biases that I practice and teach to physios, patients, and anyone that wants to learn more about shoulders. So I guess the key thing it highlights for me is making sure that we listen to our patients, we meet their expectations, we educate them, we help them meet their goals, and that can be done through a variety of management strategies. So yes, we don't know the black and white causal mechanism, but we know that we've got a lot of tools in our toolkit to help them move forward. And whether we sort of pull out one at a certain time or the other, I've got my certain things that I like to go to most of the time that work most of the time in my experience, but that doesn't mean that's right or wrong, and if someone else does it differently, that is wrong either. So it's about how we can kind of build that patient experience, build that program, and get their buy-in. So this is sort of why, I've built my 12-week online shoulder course to help physios or other allied health clinicians improve their confidence and knowledge when it comes to assessing and managing shoulder conditions. So we'll cover topics such as rotator cuff related shoulder pain, instability, the stiff shoulder with frozen shoulder and OA, and looking at other sort of kinetic chain contributions to shoulder pain. So if that's something that interests you, would love to hear you reach out, send me a DM, jump on my waitlist. I can send you the link, or I'll post it in the comments below. But anyways, I just wanted to thank you for your time. Would love to hear your comments. So post something down below, and we'll start some conversation. Thanks, team. Cheers.